Hello, and welcome to another episode of the Aligned and Elevated podcast. I'm your host, Dr. Allison Feldt, owner of Body Motion Physical Therapy, pelvic floor physical therapist, and owner of AF Wellness Coaching. I am so delighted to come in hot today to come talk to you about what it needs to look like in order for your postpartum physical therapy evaluation to be successful, and what we are looking at to set us up for a recovery plan of care, and therefore be able to go back to the gym, get back to what we love doing, and whether that is sports, just walking with your kiddos, keeping up with your kids, or you want to train at your CrossFit gym, or go back to bar class, or go to Pilates, or go to Orange Theory, whatever it is that you want to do, we want to make sure that your postpartum pelvic floor physical therapy evaluation sets you up with the plan that you need in order to transition you back into building into that fitness of your choice or whatever activity or function of your choice. So I want to get into talking about what that pelvic floor physical therapy examination needs to look like. Nothing drives me more mad than having someone say they went to pelvic floor physical therapy, they did one internal check on their pelvic floor, and then they gave them some exercises, maybe they did a few sessions, and they were good to go. Like, that's not pelvic floor physical therapy for postpartum recovery, okay? I don't care how you slice it. I've never met a pelvic floor that needs just one visit after you have a baby. Even for our clients that do substantial birth prep work during their pregnancy, they need recovery postpartum. When a baby comes out of the vagina and the pelvic floor overstretches, you get those micro tears throughout the entirety of the pelvic floor. And so you have to work on healing those. And after you heal postpartum, you're not just, the pelvic floor isn't just overextended and loose and lax. That's not what happens. By the time the client gets to you at the 6 to 8 week mark, that pelvic floor is fully recoiled and is working overtime a lot of the times in order to help drive the pubic bone and drive the ilia back together into that closed pelvic position. And so that pelvic floor typically is over facilitated and needs to work on opening and releasing and getting that eccentric strength back so that you can have that full range of motion and have that really solid, good core strength. So that's my tangent on the need for postpartum physical therapy. If you're just checking the pelvic floor and being like, squeeze my finger, relax, let it go, you're good to go. That's not adequate ever. And especially postpartum. Postpartum, you might not even be able to see if someone has a pelvic organ prolapse because of how constricted and tight it is just from the compensation of the pelvic floor trying to close back up after that childbirth experience. It might take you a few sessions in to be like, oh yeah, I do see a little bit of descent of the bladder, or I release some scar tissue and you're like, oh, I do see a little bit of a rectocele. Okay, now we know what we need to work on and what we need to heal. Same thing with diastasis. You might not fully see the extent of the diastasis when a patient comes in, especially if they're just not back to pushing their exercises yet. And so making sure that you're checking thoroughly the body. So here's what I do. This is where I start. So when the client comes in, we take a thorough history of their childbirth, going through the nitty-gritty details of their childbirth. We do this through a free consultation. Once I get all the details of that childbirth and figure out what their body went through, I can really hone in on what I want to look at. And then I take a look at, okay, what did they do for exercises during pregnancy? What do they like to do? What do they do in their previous life that they're hoping to get back to? And we take into consideration every single goal and where they see their body or want their body to be in that next year. And if that's pregnant again, then perfect. We have some goals to set up for that and what we want that delivery to look like and that pregnancy to be experienced as. So I really make sure that we get that full history and then tie that into the goals. Then once we get that and we can have clarity on where we want to take this person and help them get to, so they can feel successful in their own bodies and feel good about what they can achieve and do, then we start to go through the whole picture. So yes, I'm looking at posture. I'm looking to see, do we have iliac rotations? Do we have sacral rotations? How is the pelvis open? Is it closed? What's going on in the pelvis itself? Okay, I'm looking at hip mobility. Do they have extension back? Are they able to get some extension? I'm looking at gait. Are they still walking externally rotated? And do we need to work on bringing their feet more neutral so we can get better glute activation? I'm looking at their feet also to be like, is there any bunions? Are we having, some hallucis valgus? And what do we need to do to help support those toes so we can get that toe extension, so we can start to develop hip extension and really get our glutes to work for us, especially as we recover postpartum. And if you don't have days to do a ton of exercises when you're postpartum, at least some of the walking can be beneficial for turning on the glutes. So if we can get the feet in the proper position and really, so I'm looking at the feet, I'm looking at the toes, I'm looking at the arches. Okay, are we set up down there? And then I'm looking at the pelvis. Is the external pelvis, what do we need to tweak and shift and balance in order to create symmetry of pull across the entirety of the pelvis and the spine? Are our right hip flexors tighter? Are our left hip rotators tighter? Is that what is causing some torque here? Is what is creating the SI joint pain? Or, is that what's creating some pubic symphysis pain or some hip flexor pain? So we want to look at all of those features as well. Then once I do that and look at everything externally, I'm also looking at shoulder height and position. Is their right shoulder higher? How rounded are their shoulders forward? And we're looking at all of that, especially as they're carrying a new baby and possibly breastfeeding as well. So we want to look at those posture positions, and that's really important. Then I am looking at their lumbar range of motion, their thoracic range of motion, and their cervical range of motion. Really quick screens just to see how they're moving and how their body's recovering, and are they super, super stiff. I'll put them down on the table face down, and also as long as their chest can tolerate that. Then I'm looking at rib mobility. I want to see how is their rib moving, how's their thoracic spine moving, how's their lumbar spine moving. Then I will look at, I usually go to the belly and I'll be checking them for diastasis. So I check from the pubic bone all the way up to the sternum, to the xiphoid process, and I am checking to ensure the position of the diastasis, like how much separation do we have? And I'm also thinking, okay, what's the quality of the tissue here? Do we have a good, strong integrity of that abdominal wall, even though there is separation? And when I'm asking them to do a brief sit up or move their shoulders off the table, are they able to do that with initiating their transverse abdominis? Then I'm looking at, okay, when they breathe, where is the air going? Are they able to descend their breath down into the abdominal wall? Can we get excursion of the diaphragm? I'm looking at the rib angle, and if their ribs have started to come back together or if they're still really flared open, and making mental notes of what needs to happen in order for us to shift that. I might do some manual checks of releasing that diaphragm just to see where we're at with the diaphragm movement. Then I'm seeing, can they recruit their transverse abdominis movement? I look at this externally first. If I can look at this externally and I can see, okay, you get some you get a little bit of contraction or you get nothing at all, then we know we want to start training that transverse abdominis. Side note for later on, I also check this when I'm internal, because many, many women after childbirth will drive their transverse abdominis contraction with their pelvic floor. And so in order to make sure that we separate the two so that the transverse abdominis can really be the driver of the movement and that the pelvic floor isn't getting over recruited, then we want to make sure that we train that transverse abdominis, and we might want to train them independently so we can give the pelvic floor a break. Now, the stronger we get the glutes postpartum, of course, the better integrity, extensibility of the pelvic floor we're going to get. So we'll be able to get better contractions and better relaxations. I don't ever train contraction, truly, unless there is possibly a nerve injury and nerve damage. I find that if you can really get that extensibility of the pelvic floor, then you naturally automatically get those contractions. And again, that's the postpartum pattern. It's like you think that the pelvic floor is going to be, quote unquote, blown out. Like that's what everyone feels like they are, but it's really just that everything is restricted. There's scar tissue, there's micro tears. We got to work those out and get the extensibility. So then every time your foot hits the ground, there is that piston effect that we get, that, the Julie Weed piston effect, where your foot hits the ground and we get some upregulation of the pelvic floor, and it can move dynamically with that diaphragm. And so I am wanting that movement. So I check the TA, then I'll look at the hip range of motion, see what their hip strength is. I'll watch them walk. Then we go into an internal examination. We will look at the first, second, and third layer. We will look at organ position. I typically do the very first exam in supine, with one knee on a bolster and the other knee butterflied out onto a pillow. That pillow side is the side I'm treating and working on first. I do one side and then I switch, exit, and go to the other side of the body. And when I am looking at that first layer of the pelvic floor, I'm looking, okay, is this burning? Does this feel like a fingernail is cutting you? And do we have restriction? And if you're getting those sensations, then we have a ways to go, because we need that to go away, so you have good extensibility of the tissue. So we're going through the entirety of the first layer, and this is what we have in mind. If we have a lot of tension, and if we have a lot of that burning feeling in that first layer, then that impacts a lot of the function of the pelvic floor, and it's going to be harder for you to get good blood flow to that first layer, including the clitoral blood flow and clitoral function, and also some of the, ability to control that urethra. And so what we want to do is we then go into that second layer, and then we do the same thing. We're just checking the fascia. We're going to that urethral sphincter, checking for adhesions. A lot of times, if patients postpartum have had an epidural, you will see that the urethral opening tends to be enlarged. And so in order to help reset that urethral opening, you want to work those muscles in the fascia around the urethra in order to really get that closure that can help with continence. It can help with urgency. Then after we do that, we go into the third layer, and we're checking every single muscle in the third layer, from coccygeus, ischio-coccygeus, pubococcygeus, and obturator internus. And we are just checking these muscles. Is there tenderness? Is there adhesion? Is the client able to relax as I am checking these muscles? You give an overstretch to these muscles in order to ensure that they can move and that they can get range of motion back, because they're constricting and tight due to helping pull that pelvis back together. And if they've lost hip extension and they're not using their glutes, they're probably driving a lot of the movement that you should do with your glutes through their pelvic floor, and that's where we get these over-facilitated pelvic floors. And so ensuring that I'm going through these pelvic floor muscles and really giving the overstretch that is needed is essential for helping open that up and open up that third layer. I'm checking obturator internus. I'm checking it below the fascia and above the fascia. And if that is creating any symptoms that are referring anywhere else, I'm treating those muscles. I'm treating those muscles even if they're not creating symptoms, but I feel restriction under my fingers. If I feel scar tissue, if I feel adhesions, if I feel tension. Sometimes postpartum, I can't even get into these muscles because the fascia is so dense and tight. I have to spend the whole session just working on the fascia in order to be able to get to the muscles. And that might take me a second or third session. And so, I might be internal for 30 to 45 minutes in those follow-up sessions just to try to work my way into the pelvic floor muscle so I can see what's going on. And that right there is a skill in order to be able to do that. You can't just stick your finger inside someone and be like, squeeze my finger, you can do it, great, you're clear, that's your pelvic floor physical therapy. No, you have to work through these fascial restrictions, you have to work through the scar tissue, you have to work to get the extensibility of the pelvic floor, and then retrain the hips so that the glutes and the transverse abdominis can drive the movement, and then you can integrate your lower traps and your lats into that movement pattern so that you have a rock solid core that can really really sustain and be ready to go back to physical fitness or whatever those functions that you want to be able to do. And so that is the importance of this. And so it's really dire that every single pelvic floor physical therapist understands that this needs to be the status quo. We can't just be seeing someone 1 or 2 times postpartum and be like, you're good to go. No, we gotta like start from the beginning. We gotta get the pelvic floor mobile and get it dynamic, get a ton of blood flow back to the pelvic floor, because it just had significant change. And then once we do that, then we can really start to retrain the core and retrain the glutes and retrain it all. It all has to tie together, and this is a process. So if you tell me that you can do this for your patients in under 6 visits, I find that hard to believe that you're able to work through every single thing that needs to get worked through in order to start retraining appropriately and then building on that training so that we can be, you know, totally fit and ready for exercise. I get that not every new mom can make it for more than 6 sessions, whatever, but even if that happens over an 8 to 12 month period, at least it's starting to happen so we can retrain the tissue, retrain the muscles. This is optimal living. I'm not talking about, you know, I know that that's not feasible for everybody, but when we are seeking our health and wellness and we are trying to live at the top of our game, this is so important. And I think so many pelvic floor physical therapists, they work independently. They don't work together. They don't work with other pelvic floor PTs. And so they honestly, they don't get treated themselves. So they lose the impact at which they have on these clients. And that right there is a problem, because then you're like, yeah, of course, 1 session, 2 sessions, you're good to go. Like, no, like when you're getting this work done yourself, you know that there's stuff to work on always and forever, right? Like I've never met a pelvic floor that I'm like, oh, you're a perfect pelvic floor, I don't need to see you anymore. Like, then you're probably not truly assessing what's happening in the muscles themselves if that's what you think. If you want to talk about health optimization and wellness and full on thriving through motherhood, like you gotta work through these restrictions. You gotta get that range of motion. You gotta build on the entirety of the core. The pelvic floor and the diaphragm, they need to stay so dynamic, and then you build everything else around that. So when I'm internal, then I'm doing a prolapse assessment. I'm looking at their anterior wall. Does anything descend after a few bear downs? Does their cervix start to descend after a few bear downs? I'm looking at the posterior wall. Do I see any rectal descent or the posterior wall descent? Do I see a rectocele? I'm checking for a perineocele. I'm seeing like, okay, is there any distension where that central tendon in the perineal body come down? And then I'll check the anus. Do I see any residual hemorrhoids that we need to help heal? And I'm just looking at the integrity of the tissue, and then I'm feeling the quality of the tissue. Is the quality of the tissue more beef jerky like? Do I need to work on getting this muscle so hydrated that it turns into that juicy chicken breast, and so that we don't have to worry about tearing, painful sex, lack of orgasms, or this woman who has a beef jerky like pelvic floor doesn't have that extensibility, so that core can't fully work for her. And so we need to get that integrity of that muscle back. And so what is it going to take? And we've probably all have worked on that pelvic floor that is in their 60s, 70s, and 80s, and no one's ever touched that pelvic floor before. Yeah, they might be able to tolerate sex a little bit, but it's probably not good. Or maybe they haven't had sex for years, and those muscles are extremely dehydrated, and those patients lost estrogen a long time ago. And you don't necessarily need estrogen to get that hydration back. You just need those muscles to be able to open up and be extensible, so then the blood can start flowing to those muscles again. Then you also generate more natural lubrication. And so that is where a lot of the responsibility lays for a pelvic floor physical therapist to really truly heal the pelvic floor postpartum. Now, if I'm not seeing a pelvic organ prolapse and the patient is feeling pressure and heaviness, I'll definitely check it in standing. in the beginning, I'm really working on just opening up that pelvic floor. The more I can open the pelvic floor, the more there is room for those organs in the walls to go back to their places. But if I have a grape and that's my bladder and my anterior wall, and my pelvic floor is so tight that it's squeezing that bladder, that's going to create further descent. So I need to help open up that pelvic floor, releasing these muscles, decreasing that pressure on that bladder itself, so that bladder and that anterior wall can go back into its place, and then I can start to retrain my TA to drive the movement to help support the bladder, which, there's a little ligament, like urachus ligament, that goes from bladder to TA, or from TA to bladder. And so if we can get the TA to drive the movement before the pelvic floor, that helps pick the bladder up. And so therefore you're going to help decrease the symptoms and heaviness of the prolapse. But if your pelvic floor is picking up first and your organs are below the line of the pelvic floor, you're just increasing your downward pressure on that pelvic floor and on those pelvic organs, creating that pelvic prolapse to be a little bit worse. And so it's important that we work on this opening and this facilitation of getting that eccentric strength so that these organs and the walls have places to go and go back to their homes. So these are the things I'm looking at from a postpartum evaluation. I'm also looking at, I'm sure I'm leaving things out, but I look at visceral motility. I look at to see how much they're driving movement with their obliques versus their transverse abdominis. When I'm internal and I ask them to do a TA, if their pelvic floor does everything and is just squeezing my finger and I can barely feel the TA, that's where I'm like, okay, we need to work on dissociating. We need to get this pelvic floor open. And can you contract the TA and leave the pelvic floor open? This helps manage intra-abdominal pressure. This will help heal a diastasis. This helps heal the abdominal wall. And this will improve your patterns long term, so that you can use your core functionally. Because if your pelvic floor is doing the work for the TA, then you're going to be getting a real lazy TA, and that TA isn't going to do much for you. And then you're going to get a lot of the moms being like, why do I have this mom pooch? Or why, I don't, they're going to end up with issues later on because they're not driving their movement with their transverse abdominis muscle. So this is just really everything I've seen clinically, and this is where I focus on, and to try and build people back, build the postpartum body back by truly making changes through the pelvic floor, re-educating the TA to do a lot of the work, and re-educating the glutes and the hips to do a lot of the work in order to unload the pelvic floor. And then also when you have that like mid-back pain or mid-back spasms postpartum, a lot of times it's like, okay, we just got to get that diaphragm moving again and really allow the ribs to come back together with some core work and with some lower trap and lat work. And that will help take a lot of that pain out of that mid back and a lot of those spasms out of the mid back. And we have to integrate working on the low back, working on the lower traps and the lats, and integrate that into the TA. And that is challenging. I mean, every single lift I do at the gym, that's the goal, right? It's like making sure your core is turned on. Am I able to stabilize my skeleton by activating my transverse abdominis and activating the lower traps and the lats? And can I do that and also then do the bicep curl, or also then do a row, So it's like these are the essential components of what you're looking for in your postpartum evaluation. And then you work on getting through the restrictions. Don't waste the client's time by, counting out their exercises for them. Do the manual work to get all the pulls on the pelvis normal, right? Like balance the pelvis as much as you can. If you have one obturator really cranking inside one side of the pelvic floor, and then you have your hip rotators or your pubococcygeus cranking on other sides, you're going to create asymmetrical rotations inside the pelvis. And our goal as PTs is like balance the pelvis, balance the spine. We want to balance the pulls so we don't end up with an SI joint pain on one side, or so we don't end up with sciatica on the other side. We didn't even talk about C-sections, but like you have to be looking at that scar, and you can't just like move the skin and see if that scar is moving. No, you got to get into that scar. Once you release that first layer, okay, now where is that second layer going? Can you start to really differentiate all the layers? Can you feel down into deep into the uterus where that scar went. And, you know, really making sure that you're adequately diving into the scar. And this honestly takes sessions upon sessions, because you can't just heal a C-section scar in one session. The average healing time in my clinic is 16 sessions for one C-section scar. Add on multiple and it's gonna be a little bit more. And it's not because we're not adequate at releasing these C-section scars. It's because a true scar takes some serious time to change. And, you know, we even use regenerative tools in my clinic to help dissolve the C-section scars and dissolve abdominal scars. And that will help get that better recruitment of the transverse abdominis muscle. Also helps get better peristalsis. And so, you know, we want to get that normal visceral motility back as well, because the more that the organs can move inside the container of the abdominal wall, the better you can get your core activation, the better that you can manage your intra-abdominal pressure, the less likely you are to have that pelvic pressure within the pelvic bowl, and so less likelihood for incontinence and other symptoms that are related to pelvic floor dysfunction. So I hope you found this episode fascinating. I tried to make it, you know, for pelvic PTs so that they can truly deliver the care that needs to happen. You know, I actually got a little hate on my Facebook page a couple weeks ago, and when I was talking to an OT on my feed about pelvic floor physical therapy, and she's like, yeah, I just didn't have a good experience, and there's no one else around me. And I was like, just fly up here. You know, you can fly up here, you'll learn from us, then you can integrate this into your practice, but this will also be really good for your healing and your body. And someone like kind of trolled the comment and was like, no, use this, it's not a troll, I guess, but it was like, use this, or the APTA has a directory. And it's like, unfortunately, I feel like every time I refer someone, the feedback is just, it's all over the place. And that's how the training is for pelvic floor PTs. It's like, you know, PTs will do 1 or 2 courses, and then all of a sudden they're pelvic floor PTs, and they treat alone in a clinic. They don't have mentorship. They don't have someone to practice on and get practice on, so they don't get feedback. You know, they're not each working on a patient being like, does this feel the same when you do it as when I do it? And so that can be, you know, if you're not getting constant training and feedback, and it's really hard to grow as a lone practitioner, and really figure out, like, how do I get better as a pelvic floor physical therapist? Now, surrounding yourself and having these types of conversations, listening to this kind of content and podcasts, that's important. That's where your growth and development are going to come from, because hopefully you heard something today that I reminded you of that you weren't doing. And now I'm sure I missed things. You know, I'm just spewing off the top of my head over this past eval that I just did, and so this is fresh top of mind right now. And you know, if my patient had dequervians, I'm going to look at that. You know, you're just doing your best, and that's what we can do, and we can all strive to get better. And I think the more that we get better, we'll help more people, and we can truly make these changes, instead of just saying to someone, okay, great, you had 1 pelvic floor check, you're good to go. Like, that's not adequate care. People need actual restructuring of their tissue, restructuring of balancing everything around the pelvis, balancing everything around the spine, getting normal spinal and joint movement back. And that all comes with time, skill, expertise, and really giving the patient what they need. And I get that not everybody can execute on that, but this should be standard of care. So I hope you enjoyed this episode. I'm Dr. Allison Feldt, owner of Body Motion Physical Therapy, and your host of the Aligned and Elevated podcast. We'll see you next time. Like and subscribe. Share this with all your pelvic floor PT friends, or anyone that's had a baby that needs some pelvic floor PT and wants to know what to look for. Okay, take care.